When I first heard the term heart failure, I thought it means the heart has completely given up. But then I learned it's not a total defeat, but heart is trying its best, and that's changed how I see the medicine, that how our bodies struggle, So this is our today's topic, heart failure. Introduction is saying inability of heart to provide adequate organ and tissue perfusion. Like heart is unable to contract, its contractility is lost. Usually result from left ventricular dysfunction. Like this is left ventricle, left atrium, left ventricle, right ventricle, right atrium. So this left ventricle is dysfunctioned. It means that it's not working properly. That could be contractile failure or relaxation failure. It means heart is not contracting, its contractile ability is lost. That's called systolic dysfunction. And relaxation failure mean heart is not relaxing. Like normally heart is like this. Suppose this is left ventricle and this is right left atrium. So normally what happen, it relaxes, blood came from left atrium to left ventricle, so it has to relax. But if it is unable to do so, it means that it is relaxation failure. This is saying that heart failure is divided into heart failure with the reduced ejection fraction and heart failure with preserved ejection fraction. Heart failure with the reduced ejection fraction and preserved. So reduced mean if its ejection fraction is less than 40%, then it is called systolic dysfunction. It means like this is left ventricle, it is pumping blood into the aorta and it is going into the body. Suppose it is 100 ml at end of diastole, so it has to contract and it has to move forward this 100 ml into the body. Normally ejection fraction is more than 55 or 60, so from this 100 it excrete or pump 50, but if it pumps less than 40, then it is mean heart has failed and its ejection fraction is less than 40, then it is systolic dysfunction. While preserved ejection fraction mean heart left ventricular ejection fraction is more than 50%, it is diastolic dysfunction. So we'll come to the pathophysiology. First we'll see heart failure with reduced ejection fraction. Normally left ventricle systolic dysfunction due to any reason, suppose ischemia, cardiomyopathy, so left ventricle ability to contract is lost, or valvular dysfunction mean the heart valves are not working, so then there is left ventricular volume overload. Okay, this causes left ventricular stretch and increased stroke volume via Frank-Starling method. Mean if there is more volume in heart, suppose this is left ventricle, so if there is more volume in heart, it will cause overload. It will put pressure on it. Heart will increase in size, like from this to this, like this. This is left atrium and this is left ventricle. So when there is stretch, volume overload, so it causes its stretching. Thus, it initially maintain cardiac output. If chronic volume overload, then there is eccentric hypertrophy. So what is eccentric hypertrophy? This is normal diameter of heart. If I cut the heart in coronal section like this, if this is heart, I cut this portion and I'll show you this. Normally this is left ventricular cavity and right ventricular cavity, and this is myocyte. If there is eccentric hypertrophy, like blood is continuously pumping the heart, stretching the heart, so there is eccentric hypertrophy. It came from this to this. Its cavity is increased. Sarcomere added in series. So stroke volume, increased stroke volume maintained at expense of wall stress. Mean wall, there is stress on wall, but stroke volume is maintained. But over the time, when there is overwhelming wall stress, left ventricle enlargement and contractile dysfunction, then happen decompensated heart failure. He's saying that there is pressure is continuously applying for decades, for years, for after 10 years, its contractile ability is completely lost, and that is decompensated heart failure. So again we'll see left ventricular systolic dysfunction or valvular dysfunction causes volume overload. This causes left ventricular stretch increase in stroke volume via Frank-Starling method. If there is chronic volume overload, there would be eccentric hypertrophy. Heart stroke volume is maintained at expense of wall stress, but when there is overwhelming, it causes eventually decompensated heart failure. Now, heart failure with preserved ejection fraction mean ejection fraction is preserved more than 50%. So what's the why heart is failed? Why? Because relaxation dysfunction. Normally heart relax, but now it is unable to relax. Then it causes reduced compliance, concentric hypertrophy. It was eccentric hypertrophy, mean heart walls are thin. This one. This is eccentric hypertrophy. The heart walls has become thin. It was first like this, and now it has become thin. In concentric hypertrophy, it became more thick. Normally it was like this, and when there is concentric hypertrophy, the heart wall became more than it was before. That could be due to the prolonged systemic hypertension, mean there is hypertension for years, for decades it is prolonged. This causes left ventricle to become more strong and there is hypertrophy. Or interstitial myocardial fibrosis. There is fibrosis in this interstitium, that may be due to the obstructive or metabolic syndrome, like any metabolic syndrome that causes fibrosis in myocyte, then it is unable to relax. Normally it is flexible, but if there is fibrosis, then its ability to relax is finished. Now we'll discuss neurohormonal compensation and male adaptation. What I have said to you now, this one, this whole phase is asymptomatic because heart has maintained its stroke volume. Decompensated heart failure at this point, it is symptomatic. Why? We'll study how this whole phase is asymptomatic, because body try to compensate. Now heading is neurohormonal compensation and male adaptation. Look at this. This is heart. This is sinoatrial node. This is aorta. There is a receptor in aorta, aortic baroreceptor. This is carotid arteries and receptor in carotid sinus, that is carotid sinus baroreceptor. Normally when heart is unable to contract, mean less blood is pumping, then these receptor will come to know that blood volume is low. So they send signal to the cardioregulatory center in brain, in medulla. This is brain and this is medulla. So this cardioregulatory center will send message. This message will come to the three sides. The first is blood vessel. It will tell please contract. There is constriction of blood vessel to the myocardium to increase its contractility and to a node. So please heart, increase your heart rate. Why? Because the blood is pumping less. These receptors are saying, so you have to maintain that pressure. So in this way, when there is increased heart rate, increased contractility and peripheral vasoconstriction, then it tries to compensate. The other mechanism of compensation is RAS activation. What happens when heart is unable to contract? Less blood will come to the kidneys, and if there is low blood pressure in kidneys, it will cause release of renin. So yeah, renin. What renin does, it convert angiotensinogen from liver. Liver will produce angiotensinogen. It will convert into the angiotensin 1. Now angiotensin converting enzyme will convert into angiotensin 2. This angiotensin 2 cause vasoconstriction, as well as from adrenal cortex it cause release of aldosterone, which ultimately increase sodium and water absorption, and thus blood pressure is again maintained. So this is a compensation mechanism. Okay, neurohormonal compensation and male adaptation. Then it is male adapt, of course. It is male adapt. Why? Because heart is unable to contract. Now, what are the causes of heart failure? What are the causes of heart failure? We'll divide into the causes heart failure with preserved ejection fraction and reduced ejection fraction. In preserved ejection fraction, chronic hypertension, hypertrophic cardiomyopathy, these causes chronic hypertension plus hypertrophic cardiomyopathy. It will cause concentric hypertrophy, what we have studied in this one. So heart, it's diastolic, would be diastolic dysfunction. Why? Because if there is concentric hypertrophy, mean this cavity size is reduced. When there is reduced, left atrium is pumping, it's unable to pump its blood into the left ventricle because its size is small. So that's why it is diastolic dysfunction. And obesity, insulin resistance, and restrictive cardiomyopathy, all these cause wall stiffening. If this wall is stiffened, it means it is not relaxing, its flexibility is lost. That would also cause diastolic dysfunction. So heart failure with reduced ejection fraction, there could be ischemic heart disease, severe valvular dysfunction, or dilated cardiomyopathy. All these cause heart contractile dysfunction, and when heart is unable to contract, its ejection fraction is reduced. So these are causes of heart failure. Now clinical presentation. How a patient with heart failure present to you in clinic. If there is left ventricular dysfunction, mean left ventricle is unable to contract, so it won't supply the blood to the body. Then there will be dyspnea and fatigue. Why? Because body is not getting enough oxygen. And if blood is accumulating in left ventricle, so blood from left atrium is not coming to the left ventricle, and blood from pulmonary vein is also not coming into the left atrium, so there would be high pressure, capillary pressure in lungs. It is called pulmonary capillary wedge pressure. It would be increased. Then it would cause pulmonary edema, orthopnea, cough, and paroxysmal nocturnal dyspnea. Now left ventricle is contracting, but there is the pressure in the lung is also increased, so right ventricle is also failed. If there is right ventricular failure, the blood will not come from right atrium to right ventricle and from the body to the right atrium. So in the body it will accumulate, the blood will accumulate in the veins. It is called central venous pressure. So central venous pressure is increased. It will cause jugular venous distension, hepatomegaly, and left extremity edema. So these are the clinical presentation of the patient. Patient will say that I'm having edema, I feel a cough at the night time, there is dyspnea, I cannot breathe. So these are the clinical presentation of the patient with heart failure. On physical examination, with heart failure with reduced ejection fraction, you will find the S3, laterally placed point of maximal impulse. Normally maximal impulse will came, this is suppose this is clavicle, at mid clavicle, on the medial side of mid clavicle at fifth intercostal space. You can say at this point when you put your steth, auscultate, you will find the maximal impulse. But if it is if right ventricle is dilated, then it is shifted toward laterally, so then you will find the impulse here. This is sternum, this is clavicle, normally impulse is here, but if heart is enlarged, so we will find laterally. Okay, next thing is lung crackle. Because it is having pulmonary edema, so when you auscultate the lungs, the base of the lung from back, when you will ask the patient please inhale deeply, so you will find a certain sound that are lung crackles. Its JVP is raised. You can also find on examination left extremity edema, hepatomegaly, and hepatojugular reflex. It's on ECG you will find left atrium enlargement. Why? Because left ventricle is unable to pump the blood into the aorta, so blood is accumulating here. From left atrium, blood is not also coming to the left ventricle, so left ventricle is enlarged. So on ECG we will find left ventricular enlargement as well as left ventricular hypertrophy. On laboratory you do the BNB, it would be more than 100, it is highly sensitive. As well as hyponatremia, mean the sodium level is decreased due to the volume overload. Sign of advanced heart failure, it is also the predictor of mortality of the patient. So on laboratory diagnosis you will find BNB and hyponatremia as well as ALT, AST are raised, that shows that there is hepatic congestion. So on X-ray you will find cardiomegaly as left ventricle is dilated. So when you will do the X-ray, I'll attach the photo. So you will find the cardiomegaly, pulmonary edema, bilateral pleural effusion you will find on chest X-ray. So how you diagnose the patient? First is clinical presentation. Now, patient will say you, I'm having fatigue, cough, dyspnea, etc. Na, these symptoms. Then you will examine, you will find all these symptoms. So on the base, after this is clinical presentation. Plus you do the echocardiography. What you do? Echocardiography. If it is heart ejection fraction is less than 40, then you can confirm that it is heart failure with reduced ejection fraction. But if there is left ventricular ejection fraction is more than 50% and there is plus left ventricular enlargement and consistent clinical presentation, then it is also left ventricular ejection, then it is also heart failure, but heart failure with preserved ejection fraction. So how will you manage these patients? There is initial management. In initial management, recognize the clinical presentation. Suppose patient come with dyspnea, orthopnea, or other any left extremity edema. So first you has recognize these symptoms. Then you do diagnostic study. You will send the laboratory chest X-ray, BNB levels. Now after this, first you have to evaluate clinical stability. First you make sure that patient is clinically stable. If there is respiratory failure or cardiogenic shocks, why would be respiratory failure? Because there is pulmonary edema. So what you do supplementary oxygen plus non-invasive positive pressure ventilation, or you can do at last stage intubation, put the ATT, endotracheal tube, and then do the oxygen. Then if there is cardiogenic shock, it means heart BP is low, there is tachypnea, then you do the inotropes, dobutamine and miliron. The second thing is improve the symptom of the patient, mean decrease the preload. What is preload? Now blood is accumulating in left ventricle because left ventricle is not contracting. So you have to make sure that this blood level is decreased, mean preload would decrease. So how would you do this? You would do the IV diuretics like furosemide plus minus, like you can do, or plus minus venodilator like nitroglycerin, plus balanced vasodilator. Why vasodilator? So vessel would be dilate and preload is decreased like nitroprusside. The third thing is investigate precipitating factor. They investigate why these symptoms are happening. So you would do ECG, troponin, bedside echocardiography to check out valvular dysfunction. So you do evaluate clinical stability, then improve the symptom, and then investigate precipitating factors. Then address the underlying cause. Suppose if underlying cause is ischemic heart disease, then you would do the PCI, percutaneous intervention like angiography, etc. And if there is valvular dysfunction, then you will repair the wall or replace the wall.